Hi friends, I'm here to talk about diarrhea or gastroenteritis. I'm Dr. Romil Mehta from Upper Govind Nagar ERA Clinic in Malad East, Mumbai. The monsoons are here and we have a variety of common illnesses seen during monsoons like leptospirosis, dengue, enteric fever, gastroenteritis, etc. Tonight my lecture is going to be on gastroenteritis or diarrhea, which is a very common symptom among the young and the old and the middle-aged, as well as males and females. So what exactly is diarrhea? The physician's working definition of diarrhea is increased stool frequency more than 2 or 3 bowel movements per day, or liquidity of feces. Diarrhea is a common symptom that can range in severity from an acute self-limiting annoyance to a severe life-threatening illness. Patients may use the term diarrhea to refer to increased frequency of bowel movements, increased stool liquidity, a sense of fecal urgency, or fecal incontinence. To properly evaluate the complaint, the physician must determine the patient's normal bowel pattern and the nature of the current symptoms. In the normal state, approximately 10 liters of fluid enters the duodenum or small intestine daily, of which all but 1.5 liters are absorbed by the small intestine. The colon absorbs most of the remaining fluid, with only 100 ml lost in the stool. Okay, the types of diarrhea. Diarrhea can be divided into various types. The first I'm going to talk about is acute diarrhea. The etiology and clinical findings. Diarrhea that is acute in onset and persists for less than 3 weeks is most commonly caused by infectious agents, bacterial toxins, either ingested, preformed in food, or produced in the gut, or drugs. Ingestion of improperly stored or prepared food implicates food poisoning, especially if other people were similarly affected. Exposure to unpurified water, camping, swimming, or contaminated food produce may result in infection with bacteria. Recent travel abroad suggests travelers' diarrhea. Antibiotic administration within the preceding several weeks increases the likelihood of bacterial infection. Finally, the risk factors for HIV infection or sexually transmitted disease should be determined. Persons practicing unprotected anal intercourse are at risk for a variety of infections that cause proctitis and rectal discharge, including gonorrhea, syphilis, lymphogranuloma venereum, and herpes simplex. A variety of medications may cause diarrhea through various mechanisms. The second type of diarrhea, which is non-inflammatory diarrhea. Watery, non-bloody diarrhea associated with periumbilical cramps, bloating, nausea, or vomiting, singly or in any combination, suggests small bowel enteritis caused by either a toxin-producing bacteria that disrupt normal absorption and secretory process in the small intestine. Prominent vomiting suggests viral enteritis by bacterial food poisoning. Though typically mild, the diarrhea which originates in the small intestine can be voluminous and result in dehydration and hypokalemia and metabolic acidosis due to the loss of bicarbonates in the stool. Example, as in cholera. Because tissue invasion does not occur, fecal leukocyte count is absent and not mandatory to do in this type of diarrhea. Inflammatory diarrhea. The presence of fever and bloody diarrhea, that is dysentery, indicates colonic tissue damage caused by invasion of the bacteria or a toxin produced by the bacteria. Because of these organisms, involve predominantly the colon. The diarrhea is small in volume. Fecal leukocyte counts usually are present in infections with invasive organisms of the bacteria, and it is a toxic non-invasive organism that may be acquired from contaminated meat or unpasteurized apple juice and has resulted in several outbreaks of an acute, often severe hemorrhagic colitis. Infectious dysentery must be distinguished from acute ulcerative colitis, which may also present acutely with fever, abdominal pain, and bloody diarrhea. Diarrhea that persists for more than 14 days is not attributable to bacterial pathogens and should be evaluated as chronic diarrhea. The next type of diarrhea is the one which is caused during enteric fever, a severe systematic illness manifested initially by prolonged high fever, prostration, confusion, respiratory symptoms, followed by abdominal tenderness, diarrhea, and a rash, is due to infection with bacteria, basically Salmonella typhi and Salmonella paratyphi, two pathogens that cause bacteremia and multi-organ dysfunction. In typhoid fever, constipation may be present before diarrhea ensures. What is the etiology or evaluation? In over 90% of the patients with acute diarrhea, the illness is mild and self-limiting, responding within 3 days to simple rehydration therapy or anti-diarrheal agents. If diarrhea worsens or persists for more than 7 to 10 days, stool should be sent for fecal leukocyte determination, OM and parasite evaluation, and bacterial culture. Prompt medical evaluation is indicated in the following situations. Patient with signs of inflammatory diarrhea manifested by any of the following, that is high fever, bloody diarrhea, or abdominal pain. Individuals who pass 6 or more unformed stools in 24 hours. The presence of profuse watery diarrhea and dehydration, excessive thirst, dry mouth, oliguria. Frail old patients and immunocompromised patients, that is AIDS. Physical examination pays particular note to mental status and the presence of abdominal tenderness or peritonitis. Peritoneal findings may be present in infection with bacteria. The rate of positive bacterial cultures in such patients is almost 60 to 75%. Sigmoidoscopy is warranted acutely in patients with symptoms of severe proctitis, tenesmus, discharge, rectal pain, and in patients with suspected bacterial colitis. Treatment. Diet. The great majority of adults have mild diarrhea that will not lead to dehydration, provided the patient takes adequate oral fluids containing carbohydrates and electrolytes. Patient will find it more comfortable to rest the bowel by avoiding high fiber foods, fats, milk products, caffeine, and alcohol. Frequent feedings of fruit drinks, tea, flat carbonated beverages, and soft, easily digested foods, example soups, crackers, are encouraged. Dehydration. In more severe diarrhea, dehydration can occur quickly, especially in children. Oral dehydration with fluids containing glucose, sodium, potassium, chlorides, and bicarbonates or citrate is preferred in most cases to intravenous fluids because it is inexpensive, safe, and highly effective in almost all awake patients. A convenient mixture is 1/2 teaspoon salt, 1 teaspoon baking soda, 8 teaspoon sugar, and 8 ounces of orange juice, diluted to 1 liter with water. Alternatively, oral electrolyte solutions, example Pedialyte, Gatorade, are readily available. Fluids should be given at rates of 50 to 100 milliliters per kg per 24 hours, depending on the hydration status. Intravenous fluids, that is ringer lactase injections, are preferred acutely in patients with severe dehydration. Antidiarrheal agents may be used safely in patients with mild to moderate diarrheal illness to improve patient comfort. Opioid agents help decrease the stool number and liquidity and control fecal urgency. However, they should not be used in patients with bloody diarrhea, high fever, or toxicity, or fear of worsening the disease.